Hello guys, welcome back to Clinically Clear. So today let's cover the remaining contraceptives that includes hormonal contraceptives and some other methods. See, hormonal, they can be oral hormonal contraceptives or they can be depot preparations. Okay, first let's cover oral. Oral, first of all, we have combined OCPs. Combined in the sense estrogen is combined with progesterone and the combination dose is always specific. Estrogen in the form of ethinyl estradiol 30 micrograms, progesterone in the form of levonorgestrels 150 micrograms. That is the ideal combination. Okay, that's not the ideal combination, that is the combination. Okay, combined OCP is the best OCP for a newly married couple for spacing the pregnancy. Newly married couple who don't want any children, long term you won't give combined OCPs, but they just want to space their children for 2 to 3 years. Combined OCPs is the best. Okay, now there are two things available under Government of India: Mala N, Mala D. Both of them are the same dosage: ethinyl estradiol 30 micrograms, levonorgestrel 150 micrograms. It is just that Mala N is absolutely free. Mala D is 3 rupees per packet. It is just a marketing strategy. We as humans, we tend to think of something as free to be of low quality, to be not, to not have good quality, to have, contaminants, pollutants and stuff like that. Whereas if you're paying for it, oh, it must be a good quality. So by keeping a price on it, it increases the usage of Mala D. Okay, this is just a marketing strategy. Mechanism of action: the estrogen will inhibit FSH-LH release, so no ovulation. So inhibition of ovulation is the main action of combined OCPs. Progesterone can make the endometrium unsuitable for implantation, and it can also thicken the cervical mucus plug, preventing sperm entry, preventing fertilization. So it can inhibit fertilization and implantation to a certain degree, but the main action is estrogen and progesterone. Actually, even progesterone inhibits FSH-LH release. Estrogen and progesterone, they inhibit FSH-LH release, inhibiting ovulation. That is the main mechanism of action. Okay, schedule for combined OCP: from the 5th day of the cycle, you will take 21 days, every day one tablet, 21 tablets, then a break for 7 days. See, this break for 7 days should not be longer than it should not be longer than 7 days. So in the packet, you will have 7 brown ferrous fumarate tablets to take care of this break, so that the woman is still taking something to keep her in the habit of taking tablets. So 21 days OCPs, then 7 days brown ferrous fumarate tablet, then again next cycle you'll repeat the same thing. Okay, if you miss one pill, next day you can take 2 pills. You can make it up. As soon as you remember, take a pill, or next day you take 2 pills. If you miss 2 pills, use barrier methods of contraceptive and start again next cycle. If you miss 3 pills in a row, 3 days in a row, immediately take an emergency contraceptive. This is an important point. Immediately take an emergency contraceptive, because you've missed 3 pills and you've had sexual intercourse. It high chance of leading to pregnancy. So immediately take an emergency contraceptive. Okay. Now, this OCPs, combined OCPs, can be in the form of monophasic, biphasic, triphasic. Monophasic meaning all 21 days, same concentration of estrogen, ethinyl estradiol 30 micrograms, levonorgestrel 150 micrograms, all 21 tablets. Biphasic meaning all 21 tablets, estrogen concentration remains same, but progesterone can vary. Triphasic means as we progress to 21 days, there is altering concentration of estrogen and progesterone, so that the hormonal levels due to the combined OCPs match the hormonal levels during the normal menstrual cycle. Understood? Simple. That is monophasic, biphasic and triphasic combined OCPs. Advantage of combined OCPs is easy to use. Most effective contraceptive under the Government of India is this Pearl's index of less than 0.5%, and it also has non-contraceptive benefits. That is, apart from preventing pregnancies, it prevents endometrial cancer, decreases endometrial cancer, decreases ovarian cancer, benign breast disease, not breast cancer, benign breast disease, anemia, dysmenorrhea. How? By preventing menstruation. If you prevent ovulation and all, menstruation also won't happen. So anemia and dysmenorrhea, by preventing blood loss, no anemia. By preventing menstruation, no dysmenorrhea. So protective against this: benign breast disease, endometrial cancer, ovarian cancer. Non-contraceptive benefits: protection from all these. Disadvantage is the side effects. Okay, it leads to liver cancer, breast cancer, cervical cancer. That's why I put emphasis on benign breast disease, because breast cancer, it can increase risk. Breast cancer, liver cancer, cervical cancer. Metabolic side effects like dyslipidemia, weight gain, breast tenderness, headache, and the most important, OCPs, meaning thrombosis, atherosclerosis and thrombosis, deep vein thrombosis, ischemic heart disease, pulmonary embolism. All these side effects because of OCPs, long-term use of OCPs. That is why the absolute contraindication is when there is a history of thromboembolism. Already patient has had thromboembolism. If you give OCPs, increased risk of recurrence. Age more than 45, high risk of thrombol, because age more than 45, natural atherosclerosis only will take place. Along with that, because of OCP, you want to give. Already liver disease, you don't want liver cancer. Already breast cancer, you don't want to worsen. Already cervical cancer, you don't want to worsen it. So that is why these are all the absolute contraindications. Relative contraindications: smoking, already a risk factor for thrombosis. Diabetes mellitus, already a risk factor for atherosclerosis. Gallbladder disease, CKD, these are all some relative contraindications. Remember 2, 3 enough. But absolute contraindications for combined OCPs, very important. Okay. Once the woman is more than 45 years old, no way, you should never give combined OCPs as a contraceptive method. Understood? History of thromboembolism, liver, breast, cervical cancer. Why? Because they themselves promote liver, breast, cervical cancer. Okay, that is one important side effect. This CVS side effects, thrombosis, atherosclerosis, important side effect. Dyslipidemia, weight gain, breast tenderness, headache. Okay. Next, coming to combined OCPs done. Then coming to progesterone only pills or mini pills. They have only progesterone. Okay. And they have to be taken at a fixed time of the day. That is one big disadvantage. They have to be always taken at a fixed time of the day. Even if you miss the dose by 3 hours, you have to go for emergency contraception. Understood? POP or mini pill, fixed time of the day. Even if you miss the dose by 3 to 5 hours, immediately go to emergency contraception. Okay. The use is POP pills are safe in lactational amenorrhea. You should never give. One more absolute contraindication for combined OCP is lactation. Lactating woman, you should never give high dose of estrogen, because estrogen will reduce lactation. So POP, mini pills, progesterone only pills, they are the only safe OCP for lactational amenorrhea. Important. A woman has given birth, she wants a contraceptive for the next 2-3 months, POPs. Okay. But the disadvantage is high rate of ectopic pregnancy, and it has a pretty high failure rate as well. But still, lactational amenorrhea, never ever give combined OCP. Then coming to emergency contraception or morning after pill. It need not always be oral. For emergency contraception, you can always just insert a copper based IUD within 5 days of unprotected sexual intercourse. You can do that also. Just insert a copper based IUD within 5 days of unprotected sexual intercourse. You can stop the conception. Or oral, meaning within 72 hours of unprotected intercourse, you can take a progesterone only pill of levonorgestrel 1.5 mg single dose, drug of choice. Currently, the morning after pill that everyone takes, the best oral emergency contraceptive is levonorgestrel 1.5 mg single dose POP, drug of choice within 72 hours. Or SP-Lancy method, where 4 tablets of combined OCPs, then 12 hours later, again 4 tablets of combined OCPs, all within 72 hours. This is SP-Lancy method. SP-Lancy method. Or high dose estrogen for 5 days. 5 mg of estrogen for 5 days. This also you should start within 72 hours. You don't start 1 week later. Within 72 hours of unprotected sex. Or anti-progesterone like mifepristone, ulipristal 10 mg. Mifepristone, ulipristal 10 mg. This inhibits implantation. Okay. This inhibits implantation. Anti-progesterone like mifepristone, ulipristal 10 mg. Okay. So drug of choice, levonorgestrel 1.5 mg. SP-Lancy method, 4 tablets, 12 hours later 4 tablets, combined OCPs, all within 72 hours. High dose estrogen, 5 mg for 5 days. and antiprogesterones like mifepristone, ulipristal 10 mg. Or non-oral like just put in copper-based IUD within 5 days. Okay. Male hormonal OCP. For males, there is something known as gossipol derived from Chinese cotton seed oil. But it inhibits mechanism of action is it inhibits spermatogenesis. So the male semen won't have sperms. But it is not used because it can lead to permanent azoospermia. Permanently inhibit spermatogenesis, no sperm only in the semen. That is gossipol or male hormonal oral contraceptive. Now we discussed so many oral hormonal contraceptive. What about oral non-hormonal contraceptive? That is Chaya or Saheli, or the chemical name is Centchroman, which contains something known as ormeloxifene. Okay, this is a non-hormonal OCP developed in Central Drug Research Institute, Lucknow. And this ormeloxifene is a selective estrogen receptor modulator. By selective estrogen receptor modulator, it inhibits implantation. Important. This whole line is very important. Chaya Saheli Centchroman has ormeloxifene, which is a selective estrogen receptor modulator, SERM, which inhibits implantation. It is also known as a weekly once pill. Why? Because for the first 3 months of the, once the cycle starts, first 3 months, you will take weekly twice Chaya or Saheli. After that, you will just take weekly once for the rest of your life till whenever you want contraception. That is why it is known as weekly once pill. But the problem is weekly one tablet. You have high chance of forgetting it. So you miss a dose, you remember it within 7 days. Take the next dose as soon as possible. If you remember that you've missed a dose after 1 week, no use. Switch to barrier contraceptive and start fresh again sometime later. The dose of Chaya is 30 mg on day 1 of the cycle. Okay, 30 mg of Chaya, Centchroman, ormeloxifene. So oral non-hormonal OCP, Chaya, Saheli, Centchroman, ormeloxifene, CDRI Lucknow, selective estrogen receptor modulator, inhibits implantation. First 3 months weekly twice, then weekly once. That's why it's also known as weekly once. This is a very ideal contraceptive, excellent contraceptive, very less side effects. So whenever OCP is contraindicated, you have to give Chaya or Saheli. Or if a woman wants to take for a long time, OCP is obviously contraindicated. You don't want to give OCPs, combined OCPs, sorry, not OCPs, these are all OCPs only. Combined OCPs, when combined OCP is contraindicated, you want to give Chaya or Saheli itself, best. Okay. Then come into depot preparations, oral preparations done. Depot preparations, they are slow releasing, long acting. Okay. First, let's look at injectables. Injectables, you have progesterone only injectables like DMPA, depomedroxyprogesterone acetate, available as Antara in Government of India. Antara, depomedroxyprogesterone acetate, DMPA, or norethistron enantate. These are all progesterone only injectables. DMPA, you will put 150 mg intramuscular injection once every 3 months. Norethistron enantate, 200 mg intramuscular once every 2 months. So injectables. You also have combined injectables like cyclofem, cycloprovera, estrogen plus progesterone. Okay. Now, this DMPA and norethistron enantate, see, there will be a specific dose date that I have to go get the injection done so and so date. For DMPA, you can prepone by 2 weeks. You can prepone the dose by 2 weeks. You can postpone the dose by 4 weeks. Okay. For norethistron enantate, you can prepone the dose by 2 weeks and you can postpone the dose by 2 weeks. Anything beyond this upper limit that you are taking DMPA next dose 4 weeks more than the dose due date, or norethistron enantate 2 weeks later than the dose due date, then it is useless. You have to start fresh next cycle again. You have to start again. You have to switch over to a different contraceptive method. But it's basically giving you a flexible time period that, okay, let's say on the dose due date, the woman has to go to some wedding, some festival, some trip. She can just prepone or postpone the dose, right? That's the biggest advantage. So advantages when OCP IUD is contraindicated, you can switch over to injectables. Long-term usage of injectables can lead to amenorrhea. This is one important thing. long-term usage of injectables can lead to amenorrhea. So which are the injectables? DMPA available as Antara, very important, depomedroxyprogesterone acetate, norethistron and antate. Both are intramuscular, 150 mg 3 months, 200 mg 2 months. You have minus 2 weeks plus 4 weeks as a flexible time period, minus 2 weeks plus 2 weeks as a flexible time period. Okay. Combined here, cyclophem, cycloproveram. Then coming to subdermal implants. Subdermal implants, you put a subdermal implant in the forearm, long action for 6 months to 1 year. Okay. Norplant. What is Norplant? Norplant is basically you will have 6 silastic capsules, that is silicon plus plastic capsules containing levonorgestrel. So each of these capsules will contain levonorgestrel. They are implanted in the forearm. Okay, that is Norplant. Implanon is just one rigid rod subdermal implant. That is Implanon. Nexplanon is Pearl's index of less than 0.03% is the most efficacious, very expensive, but the most efficacious contraceptive till now, apart from sexual abstinence, is Nexplanon, where Pearl's index is less than 0.03%. It is very efficacious. So these are all subdermal implants. Norplant, Implanon, Nexplanon. Implanon is no longer used now. Okay. Then coming to temporary methods or spacing methods, we finished. Permanent methods, sterilization, vasectomy, cut the vas deferens. Vasectomy is very cheap, very easy. Most cost effective method of permanent family planning is not tubectomy, but it is vasectomy. Very cheap. Because the method is a non-scalpel technique, just local anesthesia, 15 minutes, keyhole technique, non-scalpel technique, done. Does not cost, costly like 2,000, 3,000, that's all. Very cheap. Very cheap. Vasectomy, most cost effective. Okay. But after getting a vasectomy, you have to tell them 15 days, do not lift heavy weights, do not strain on defecation, all that. And just after getting a vasectomy done does not mean you are sterile. Okay. For 30 ejaculations, for 2 to 3 months, you have to simultaneously use barrier contraceptive as well, because until that cut ends are completely healed and fused, not fused completely, you cut it, they have to completely heal, right? Otherwise there's a chance that the semen might still flow into it, and there's a chance that it can lead to fertilization. So for 30 ejaculations or for 2 to 3 months, use barrier as well. And tell them about the side effects, that there sometimes can be sperm granules in the testes. Basically what happens, you cut the vas deferens in the proximal part, that is, this is the testes. From the proximal part, sperm will be left behind, right? They can form some granules in the testes. All you have to give is reassurance to the patient that these sperm granules, they will disappear in 2 to 3 weeks. That's all, simple, disappears in 2 to 3 weeks. Or autoimmune reaction, another side effect, where the sperm in the proximal stump, it induces antibody formation, anti-sperm antibodies. So let's say the person who has undergone vasectomy now wants to reverse his sterility. He wants recanalization. So after recanalization, fertility now of that person has decreased by more than 50%. He's become almost infertile. Why? These anti-sperm antibodies, they're all killing the sperms. So autoimmune reaction is a big side effect for vasectomy, and sperm granules, all you have to give is reassurance. Okay. Important point is use barrier for 30 ejaculations worth. Tubectomy in females, it is in hospitals, it is done in laparoscopic, no scar, laparoscopic, known as Ischior technique, no scar, nothing, excellent. But expensive, of course, very expensive. In PHCs, they do it in the form of modified Pomeroy's technique. When do we do tubectomy? Ideally within 7 days of normal vaginal delivery or intracaesarean, you will do tubectomy. Understood? That is it for that. Post-conceptional methods, after fertilization has happened, you want to abort, right? Oral abortifacients like misoprostol, mifepristone, menstrual induction like intrauterine application of prostaglandin. That will induce menstruation, it will flush out the fertilized contents, medical termination of pregnancy, abortion. This is a separate topic in itself, where you have indications, regulations, all that stuff. These are post-conception, basically abortion. Post-conception method is basically abortion. Last, coming to something known as contraceptive efficacy or failure rate. Okay. So how effective a contraceptive is measured by its failure rate. There are two methods. The best method is lifetime life table analysis method. Life table analysis method. The most common method is Pearl's index. Pearl's index is Pearl's index is equal to number of accidental pregnancies with the usage of contraceptives divided by number of woman years of exposure to the same contraceptive into 100. How many years a woman has been using some tablet, some OCP, divided by the number of accident pregnancies with OCP usage. Okay, this one woman year is equal to 12 woman months. So if in the denominator you have woman months, here it becomes 1200. One woman year is equal to 13 menstrual cycles. So it becomes 1300 if you have number of woman cycles of exposure. Simple. Failure rate of condoms can be high, 2 to 20%, depends on the quality of condoms and depends on the usage of condoms. Okay, still 2% also is high. IUD, 1% failure rate. OCP, 0.5%, most effective under the government of India. And I told you Nexplanon, very, very effective, 0.03% or 0.3%. I'm not sure. Please go check into it. It is the most effective. Okay. Pearl's index. Basically, remember Pearl's index, they can ask as a 3 marker. And another method is life table analysis method. It is the best. Okay. Lower the Pearl's index, better the contraceptive efficacy. That's it for contraception. Thank you for watching.